It's nice to be with you again today. We're going to follow up a little bit on the issues of operational research and implementation science. And what we're going to do today, after the introduction a couple days ago, is to do a part two, which is going to really focus on the issues of the interface between HIV and substance abuse or addiction medicine. And what I will do as part of this module today is I'm going to try to review some of the basic information so that we're all starting on the same page. So we'll look at the issues surrounding both the regional and the international HIV epidemic. We're also going to try to review the relationship between HIV and drug use itself. We're going to try to discuss some evidence-based interventions for treating opioid dependence, and we're going to use the international literature for this. And then I'm going to go back and just reorient everybody for maybe 2 or 3 slides. I'm going to go very quickly through that part and just really reorient everyone about the issues of operational research and implementation science so that I can remind you as I begin to then apply it to an example of how it needs to be addressed here in Ukraine, where I am right now. And the example that I'm going to use is going to be an example that is actually underway. So I'll be able to share with you some of what works, what is a challenge in it, and so that it has some real world applicability. So let's first of all start about talking about the global burden of HIV. And globally, there are now 34 million people infected with HIV. Only 1 in 5, or 6.5 million, are on antiretroviral therapy. And unfortunately, there are still 2.7 million new infections annually. And what's interesting about these new infections is that they aren't happening to the same extent in every single region of the world. And in fact, across the entire globe, the number of new infections has actually dropped by almost 20%. But many, and it's even higher than that in many sub-Saharan African countries, where it's dropped by even more than 25%. And part of the reason for the drop globally, and especially in sub-Saharan Africa, where the epidemic is the most devastating, is that they started a program that was called 3x5. And that really meant that it was to get 3 million people onto antiretroviral therapy by 2005. And they didn't achieve it by 2005, but they did achieve it by 2007. So they were a little bit behind. Now, what's interesting is that despite the fact that the global epidemic is down 19%, it's markedly down in sub-Saharan Africa. In this region of the world, in Russia, Ukraine, and Central Asia, it's increased by 19%. So we have an unequal epidemic, and this is an area of the world where they really did not get enough people onto antiretroviral therapy. So what we also need to recognize is that the epidemic in sub-Saharan Africa is driven primarily by sexual transmission, but here in Eastern Europe and in Central Asia, it's mostly driven through the injection of drugs. So let me just take a look at why it's important to get as many people as possible onto antiretroviral therapy. And in this figure, you can see in the dark line, the dark green, that this is the proportion of people who are receiving antiretroviral therapy. And what you see is the yellow line, which is going up ever so slowly, actually decreases as you begin to get enough people onto antiretroviral therapy. And the reason for that is that it decreases death, so you have more people who are living. But what it also does is it decreases transmission simultaneously, because if you can put a person onto antiretroviral therapy, and if they take it correctly, it can actually reduce transmission by almost 100%. So this is the whole idea of treatment as prevention, and it's probably the most effective, well, it's probably the second most effective way to reduce HIV transmission in this part of the world, but the most effective way in sub-Saharan Africa. So now let's talk about what's happening locally. So that's the global epidemic. In this region of the world, the HIV is primarily driven by injection drug use, but there's evidence that it is a transitioning epidemic, which means that the epidemic has a significant proportion of individuals who are transmitting it sexually. So we're kind of in the transitional period, even though the most infections are still among people who inject drugs. Unfortunately, even though we know that provision of antiretroviral therapy reduces morbidity, mortality, and also HIV transmission, less than 2% of HIV positive people who inject drugs are actually receiving it. So even though these countries in Central Asia and Eastern Europe have got about 19% coverage, if you look at the people who are actively injecting drugs, it's less than 2%. Part of the reason for that is that many of these regions don't have the best medication for the treatment of drug addiction, so that's not available. Healthcare systems are also not organized in a way to treat more than one condition, such as drug use and HIV and even tuberculosis, which is the most common opportunistic infection. We also, in fact, the care is actually quite fragmented. There's also negative attitudes by healthcare providers towards HIV positive people and people who use drugs, and vice versa. So there's a long-standing history of mistrust, and that leads to problems with utilization of healthcare. Now, the interaction between injection drug use and HIV is really quite an important one. Globally, the most common drug injected is opioids, heroin, shirka. It has many other names, but there seems to be some evidence that there is emerging use of amphetamines. We have at least 3 medications that are approved for the treatment of opioid addiction. We have about 45 years of experience using methadone in the international community. This is a complete opioid agonist, which means that that it actually acts in the exact same way as heroin. It stimulates the mu receptor in the brain, but it doesn't have the highs and lows that heroin does. It lasts in the body for a long time, so it's much safer. Buprenorphine, we have about 16 years of experience, most of it starting in Western Europe, but now widely available throughout the world. And this is a partial agonist and partial antagonist, which means that it, in part, blocks the receptors and makes it much more safe to use than methadone because there's no risk of overdose. And then more recently, from a trial that was done in Russia, the use of extended release naltrexone, which is an injection of a complete opioid antagonist, which means that if a person is on the naltrexone and they try to inject on top of it with heroin, they feel absolutely nothing. It's like they've wasted their money. So let me draw you to a recent article that was published about 1.5 years ago by Daniel Wolf and others, and it looked at the antiretroviral coverage of among people who inject drugs in 5 countries where HIV is a problem and drug use is. And for instance, on the far left, you can see that in Russia, 83% of the infections are due to injection drug use, but only 20 to 30% of people in the country who have HIV who need it are getting antiretroviral therapy. If you go to China, it's not quite as injection drug use is not quite as important, but still significant in almost 40% of patients, and only 10% of patients are receiving antiretroviral therapy who need it. In Ukraine, where I am today, and where we're going to look at our example, about 60% of IDUs are uh, represented as part of the total HIV cases, and only 24%, or 1 out of 4 individuals who need it, are actually getting antiretroviral therapy. And similarly, you can see the data in Vietnam and Malaysia. But the bottom line is that in these places where injection drug use is very prevalent, very few of them are getting antiretroviral. Now, here's the sort of coverage, and this is important because here is the coverage with regard to for the treatment of opioid addiction, whether it's buprenorphine or methadone or extended release naltrexone. But essentially, you can see here that the biggest epidemic of injection drug users is in China, and they have about 4% of their population who are receiving medication-assisted therapy. In Russia, among the almost 2 million injection drug users, nobody is receiving it because it's banned by law. In Ukraine, less than 2% are receiving methadone or buprenorphine, and these are numbers from a couple of years ago. It's actually increased in many of these countries, but still not enough. But if you look across the board at all of these countries, coverage is really low. And what I'm going to show you is part of an implementation science research project which looks at how much coverage do you need using methadone or buprenorphine in order to reduce HIV transmission. So for the next couple of slides, I'm going to review a few of the slides, almost the same, that we did from a couple of days ago, and really just to define what implementation science is on a broader scope and what operations research is at the clinic level. But it is a scientific study of methods, so the types of studies to promote the integration of research findings, that is, what is the evidence basis, into healthcare policy and practice, and then to ultimately improve the healthcare delivery system. So, as I pointed out a couple of days ago, an evidence-based intervention is something that has been proven in a randomized controlled trial to be effective. And so that is the sort of evidence that we use to say that something is an evidence-based intervention. It has the highest level of recommendation by the scientific community. And I gave you a couple of examples of this. But evidence-based interventions may fail within a single clinic, a region of the country, or within an entire healthcare system. And that's where implementation science begins to tell you the issues around how is it working and why is it working or not working in some regions. As I pointed out a couple of days ago, there are a range of skills that are important, anything from engineering to epidemiology to policy analysis, etc. So many of these things come together in order to allow us to do effective implementation science and operations research. And many of the methods that are used are quasi-experimental, which means that they're not a randomized controlled trial. So we might look at what's going on before you do something to the system, you change the system, and then again afterwards and see if you've improved it in some way. You might compare a number of factors all at once. You can do cost effectiveness studies, and that is a type of implementation science that is really targeting the health system. So it's the broadest level, but maybe not the single clinic or a sort of regional area. So that is kind of reserved for the highest level of implementation science. There are qualitative methods such as focus groups and semi-structured surveys, quality improvement models, etc. So we have a number of methods that we can bring together in order to successfully do our operations research. And the reason why I remind you of those is because you're going to see in the example that we have here in Ukraine that that we use many methods. So these operations research really tries to answer the question, how does it work? Not does it work, how does it work? And what parts of it work and what doesn't and why? So we're trying to figure out the processes that are occurring within a system or within a population to improve outcome. And what we really try to do is we try to say if one or more parts of an operation or a system is changed, what can you expect to be the desired outcome if you do that? So in other words, you might change 5 things and it may result in no outcome because changing one of those things results in a good thing, but the other 4 are going to result in a bad thing. So it's really about examining those processes in a sort of a stylized, organized, and scientific way. And if you find that the dissemination of your evidence-based intervention is as good as the actual evidence basis that was found in the randomized controlled trial, then you can say that your dissemination is complete. But oftentimes, the way it works in the real world is never quite as good as it is in an idealized randomized controlled trial. So let me just kind of walk you through the steps as an exercise. And I'm going to use my own research project here in Ukraine to kind of tell you how we do it. And it's a grant that's funded to do operations research of substitution therapy in the country. So first of all, we know that in Ukraine, we talked about the problems are that there's insufficient substitution therapy or medication-assisted therapy. We saw that the numbers was less than 2% coverage. We know that most of the HIV-positive persons are not on antiretroviral therapy, and so we are trying to figure out how do we actually do this. And in Ukraine, even though there are currently about 6,700, 6,900 patients on substitution therapy, the problem is that it hasn't really increased in the next year. So first of all, what we recognize is we have to decide what is the evidence basis. And as I pointed out before, this is the region of the world where the HIV epidemic is actually increasing by greater than 25%. So we have to do something to halt the epidemic. So what we did was we chose as our first intervention to study is methadone maintenance because we know that it is effective and it's very inexpensive. So what we know is that methadone maintenance therapy, that is continuation of methadone versus detox and counseling, kind of psychological counseling, which doesn't work very well at all, results in a number of important outcomes. It is more likely to result in retention in drug treatment. That is about 6 times, really about 7 or 8 times higher if you give them methadone. It decreases HIV transmission 6-fold. It is associated with less overdose and death. It decreases criminal activity. It improves the engagement in HIV care. It increases employment. It increases social functioning, and it increases quality of life. So we're using an intervention that we would expect that would have a lot of positive outcomes. What do we know about methadone compared to buprenorphine or even extended release naltrexone? Well, first of all, it's the least expensive, so it's a cheaper intervention in general. It typically, for it to be effective in the trials, has to be used at reasonably high doses of 80 milligrams per day or more. So one of the sort of implementation science findings could be that patients who get too low a dose of methadone really aren't going to benefit that much. And in fact, the international experience suggests that the average dose of methadone is way too low. And so that could be one of the sort of findings that we figure out that either makes methadone not work or not. And one of the limitations of methadone, almost anywhere, less so in England and in Germany, but it's very strictly regulated so that patients must be supervised every single day and they have to travel to get it. And if you have to work, that's a problem. So you have some transportation problems. Transportation can be expensive for some patients. And if they're trying to work, it may actually not improve employment, which is one of the outcomes that you'd like to see. So now that we've decided on an intervention and we know a little bit more about it, so we know what methadone is, the next step is to make sure that you decide which research questions you want to answer by understanding the problem first. So some of the questions that we pose to ourselves in this study is changing the dissemination of methadone likely to yield successful results? And we had to define. For the purposes of our study, we're going to define it as increasing the likelihood of getting onto methadone if you're not on it, and decreasing the likelihood of getting kicked off of methadone if you are on it. So we're going to try to improve retention. We're going to try to look at how medication-assisted therapy is being provided, and is it expanded throughout the region or the country as anticipated. And one of the things that we know is that by this time in 2012, they were supposed to have 12,500 people on methadone, but only just under 7,000 are actually getting it. And what can be done to improve the sort of expansion of delivery of methadone throughout the country? So therefore, what we recognize here is that substitution therapy is our evidence-based intervention. It's relatively new to Ukraine. So the first substitution therapy became available in 2005, and that was buprenorphine, and then followed by methadone in 2007. These settings are very highly structured, even more structured than I've seen anywhere else in the world. We know that almost no patients with HIV and on substitution therapy are getting antiretroviral therapy, and we're way behind the dissemination plan. So the question is why, and how do we actually improve it? So let me show you the first sort of study that we did. Was we wanted to say, you know, is methadone the right answer, or do we need to do methadone and something else? So the first thing that was done, and I won't go into a lot of the details, but this is a sort of a cost effectiveness study looking at both effectiveness, that is, how well is it working, and can we do it for the least amount of money to really improve outcomes in the epidemic in Ukraine. And the outcome of interest that was done by this modeling exercise is to examine the number of HIV infections that were avoided. In other words, we know that giving antiretroviral therapy reduces HIV transmission, and we also know that giving methadone reduces HIV transmission. And what you can see in the third bar is that if you have individuals who are on, that you have coverage on methadone that is approaching greater than 25 to 30%, that the cost for averting a single HIV infection is about $530 US. And I think if you multiply that by 33, that would be the cost in rubles. So I guess you can do the math faster than I can. If, however, you just want to roll out high levels of antiretroviral therapy, you want to get 40, 50, 60% of people onto antiretroviral therapy, you avert about the same number of HIV infections. So it's about equal with regard to reducing HIV transmission. So they're both very effective. The problem is because antiretroviral therapy is more expensive than methadone, that what you end up doing is you do the same thing, but it costs 4 times as much. So, we can say that both of them are equal at reducing HIV transmission, but one of them costs more. And then, of course, the sort of best model is to have high levels of coverage, so 25 or 30% of people on methadone and 40% of people on antiretroviral therapy. Ideally, we'd like 60, but 40%. And you can actually avert many, many more HIV infections, twice as many, and you can do it for an intermediate cost per infection at about $1,100. So if you take a look at that model, the best model is doing both at high levels. The most cost-effective model, however, is actually just expanding methadone therapy and getting a large percentage of patients onto treatment. So that's really, it kind of proved to us that we really needed to focus on the methadone, and we know that at least in Ukraine, if we can get people onto methadone, we're increased likely to get them also onto antiretroviral therapy. So one has a benefit on the other. So what do we know about cost effectiveness research? It's a type of operations research that suggests that if you spend X amount of rubles, you can expect certain kinds of changes. So in this case, if you could spend 1,100 US dollars, I guess that would be 33,000. If you spent 33,000 rubles, you can actually avoid a lot of HIV infections. So that's what the model does. It typically works, however, on the healthcare system and not on the local clinic. So it's the largest form of operations research. And the reason why the methadone is the most cost effective is that it's cheap, but the relative effectiveness says that you should actually do both. So let's take a look at what's happening in Ukraine, because we've done the modeling now. Now let's take a look at what's happening in reality. So as you can see that we were supposed to have by this year 12,500 people onto methadone and buprenorphine. The problem is that in this last year, we've only gotten really up to about 6,500, 6,900. It's quite low, and you can see it's almost flat. So we've done almost nothing to increase the amount of patients on methadone. And so the question is, remember with operations research, why is it that we're not achieving the outcome that we want to do? And 1 million people have given me reasons for that. So let's examine the whole situation scientifically. So overall, in the past year, where we have flat numbers of patients on methadone, did the number of programs, not individuals, decrease? Because if you shut down or didn't open up new programs, then of course you wouldn't expect the numbers to increase. So we looked at that first, and actually it was just the opposite, that there were 14 new programs that were added, but yet the numbers didn't go up. So that wasn't the answer. So what we learned was that the capacity, the number of people for whom they had money to put on methadone actually increased, but the real patient number did not. So once again, here's our operations research question. Why is it that there was no increases despite the fact that the number of slots did increase? So was it related? These are the questions. Was it related to the patient factors? The patients weren't motivated, they weren't educated, they weren't getting reinforcement to sort of to stay in the program. Were they told that they should not keep coming to the program after they were on it for a certain amount of time? Or was it related to the program? Were the programs not responding to the patients? They didn't call them up to get them on the program. There could be a million reasons that the program wasn't working, or was it related to both? And so here's the question that we're trying to answer. And we don't have an answer, so I'm just going to give you the science for how we begin to do that. So with regard to operations research, it's a very broad discipline that uses essentially mathematics to sort of decide what's going on. So the sort of terms that we're going to try to use in this whole evaluation is the following. So let's define some terms. The first one is capacity, and that is that with the amount of money that they have, that this is how many slots that they could potentially put patients on. So that's and that's an important place to start. Now, what we have to recognize is that capacity is dynamic. It can go up or it can go down based upon funding. So we have to take into account changes in capacity. The next issue is the number of patients that enter or entry into substitution therapy. And we can calculate a rate. Patients come in. We have 5 new patients per month as an example. So we can calculate a rate for that. We can also calculate a rate for leaving the program or attrition. And we can say that it was 5 patients out of 100 left the program. And if you have 5 patients entering and 5 patients leaving, then you have no increase in your capacity whatsoever under those circumstances. You have reached equilibrium. So remember that the dynamics are also a function of time, whether you want to measure it weekly, monthly, annually. So we can determine that up front because some seasons may be different than others, so you want to know on a regular basis. So let's go through the conceptual model. We first have, as our model, we have in blue the sort of total amount of slots that are potentially needed. So if we know that there are 300,000 injection drug users in Ukraine, that's the total number of drug users. But in yellow, we have the capacity, and that's the number of treatment slots that we have. And we might want to say that we have the capacity to put 10%. So let's just say 20,000 people onto substitution therapy. But we know that in 2012, we only have 6,500, and that we can, at the end of 2013, we might have 9,000. So we know that that can change. So that's our capacity, and the change can occur, and all of that is in yellow. Now, in the green, we have our sort of rate of entry. So if you want to think about this as a sink, we have water coming in, and we have a drain on the bottom, which is the water going out. So the the water going in is our entry, or the number of patients that enter substitution therapy. And in the red, we have the attrition, the amount that they're actually leaving from the facility. And so what we know is that if the entry in the green is greater than the attrition in the red, there will be an increase in patients who go on to substitution therapy, or the capacity can increase. And that's the only way it can work, and vice versa. So let's talk about what we're going to do as part of our research methods, or operational research methods. So first of all, we have to get objective measures to define and expand the possible entry and attrition indicators. So what is it that's working and what is not? Now, if you were going to do this, you would have to figure out where to study this. We know that there's about 140 programs, so which programs do you study? And what we decided was that we wanted to look at places where the attrition was either high or low, because there may be something that's unique and different about those kinds of regions. We wanted to sort of use qualitative and standardized survey methods to look at 3 different groups of folks. We wanted to look at whether what was going on that was working for people who were on substitution therapy. We wanted to look at, for people who had previously been on therapy but left it, why did they leave? You know, was it that they had to go to work, or it was too far, or they didn't have money? So we have to get objective measures for why they left therapy. And then there's a whole group of people out there. We know that there's a whole group of people out there who've never ever been on substitution therapy. Is it because they don't know that it works, or that they have negative attitudes, or they don't want to be a registered drug user? So we have to define all of those reasons, and we have to do it by really going out and doing qualitative work in each of the 4 regions. And then we have to do an assessment to determine what are the most common and likely reasons why people don't actually get into and stay in treatment. The other thing that we have to do from an organizational level is we have to review the policies and procedures for OST programs. Are they the right ones? Do they differ in areas where there's high attrition or low attrition, or high entry or low entry? So we have to take a look at the policies and procedures. So here's the first thing we did. And what we did was we looked at several different regions with substitution therapy within Ukraine. We looked in Lugansk, Vinnytsia, Kherson, Poltava, Krim, Dnipropetrovsk, Donetsk, Odessa, Mykolaiv, and Kyiv City. So these were some of the big programs. And what we did in red was we looked at attrition. So how fast do people leave the program each year? And we can see that a place like Mykolaiv is a place that has a high level of attrition. That means people leave the program almost as fast as they come in. If you look at Dnipropetrovsk, where the capacity is the biggest, there are almost no patients that have an empty slot, but we know that attrition is modest. It's in the middle. So with about 40% of patients actually dropping off the program, but somehow they're able to bring them back in. So we could choose a couple of these regions like Dnipropetrovsk and Odessa and Kyiv City in order to try to test what's going on. So the next thing we wanted to do is, because these are absolute what I call monitoring and evaluation, we wanted to start to create something that was called an efficiency. And the efficiency is the entry of going into it divided by the capacity, so the number of new patients divided by the capacity. So if you have high entry into the facilities, it's very efficient. And we used a cutoff of 50%, and that's the red line that's in the middle. And then we looked at the attrition efficiency, which we'd like to be low. So it's the number of patients who leave based upon the capacity. And what you can see is that when you take a look at some of the sorts of facilities like Dnipropetrovsk and Odessa and Kyiv City, in which there's a green star, you can see that there's incredibly high levels of entry into both of them. So they have very good entry for the most part into the city. But some of them, in fact, all of them, have even higher levels of attrition. So more patients are leaving than are coming in. So the number of patients within those programs is actually decreasing. If, however, you look at the red patients, where the red star is, that you can actually see that the attrition efficiency is so great. They're losing them so fast, and the entry going into them is much, much lower. And so these would be the worst programs in terms of being able to keep their patients. So these are the places where we might want to decide to do some sort of intervention. Now, what do we know based upon the sort of monitoring and evaluation, if you will? And this is where monitoring and evaluation doesn't work. So if we ask the treatment programs, so these are the people who are making decisions about who comes in and who goes out, they told us that the #1 cause for why patients leave the program was they just didn't know. 1 out of 4 people, they said, we don't know. So what we have to do now is we have to go out into the field and we have to figure out why that they don't know that this is the case. So that's the first question for us. And we're going to do that through qualitative methods and semi-structured methods. We know that a similar proportion of patients is that they're being discharged from the program. And this just means that they're being discharged usually because the narcologist says, I don't like you, or the nurse doesn't like you, and they kick you out of the program. And so we have to work with how the staff and the patients interact. Is it that the patient is doing something terrible, or is it that the staff doesn't like drug users? We don't know. All we know is that is one of the most common reasons why patients leave the program. Over 10% leaves the program because they get arrested. we've done some studies looking at the arrests of these patients who were on substitution therapy. And what we know is that the police stand right outside and harass them. And if they don't bribe them, they take them to the police station. They lock them up in the interrogation unit. They watch them go through withdrawal and try to get a confession or a bribe out of them. So this is one of the ways that we're going to work on this, is we're going to work with the police. We know that a similar proportion just didn't like OST. They didn't say it was good for them. And then, of course, what are the other causes? And so this is part of our formative initial work. And you can see that our first aim is to look at what are the client levels of barriers and facilitators to substitution therapy, and what are the program level barriers and facilitators. And we're going to do that through the sort of qualitative methods and semi-structured surveys. Once we do that, we're going to establish a group of outcome indicators for both entry and retention. So what are the list of reasons for entry? The staff doesn't like them. It's too far away. We're going to make a very complete list because we don't know what it is at this time. And then we're going to create a matrix, just like we just did, of the programs that perform very well with regard to entry and retention, which is the opposite of attrition, at various performance sites so that we can actually have an impact on the individuals. Here are the data that we've already found from our qualitative and structured interviews. What we did was we looked at 97 individuals who were previously on substitution therapy, so they were kicked off the program. And we found that police harassment was one of the most common reasons. And what we found was that 59% of the subjects reported a total of 286 unofficial detentions. So this is about 3.5 detentions per person. So that results in 1 detention for every 40 days of observation in the previous 6 months. Many have reported that bribes were often not paid, and they were therefore detained because they didn't have any money. What we know is that 85% reported that the police harassed them on the way to substitution therapy. So once again, this is something that we can have an intervention with. We can work with the teams in order to improve the police from interacting with them this way. 62% experienced abstinence syndrome, so we're going to try to work with the police stations to make sure that we can continue methadone there. And if they were on antiretroviral therapy, they were likely to have their antiretroviral therapy stopped. What else have we learned? We did learn that transportation was problematic. For many, it was too far and too expensive to go to every day. So can we change the rules so that they can come to the substitution therapy twice a week, for example? And that might be able to keep people for longer periods of time. We also learned that many individuals who were not who were not employed, once they quit using drugs, they were able to work again. They were doing well. But the narcology center operations are only from 9 to 11 in the morning. So if you have to work a job from 8 until 5, like all of you, you couldn't go to your substitution therapy and wait in line because they were not flexible. So we're going to work with the programs to become a little bit more flexible. Some people, not as many, felt mistreated by the staff. If they had to leave for a weekend, let's say for a funeral, they were kicked off of the program for missing a couple of days. And then some people were kicked off because they would use other drugs or drink alcohol, and that was a reason for dismissal from the program. So we've done some of the qualitative work, and now we have the right questions in order to do the assessment. So the third step is to plan your operations research study using the right scientific approaches. As I mentioned before, we've already started. We're doing qualitative research, but the qualitative research will tell us why, but it won't tell us how much. So we then have to have survey research in order to tell us how much, because we're interested in both. We want to know how and how much. We are going to do a quasi-experimental study where we're going to look at the entry and attrition from the methadone program in the 6 months to a year before we do an intervention. We're going to then intervene with a model that is a quality improvement model. And then we're going to look at entry and retention afterwards and look to see whether the poor performance sites actually improved. We're going to use some mathematical modeling, and we're going to use some systematic dynamic research to take a look at how systems actually respond. So part 2 of this project is a pre-intervention assessment where we look at these indicators. The sort of intervention that we're going to use for part 2 is the NIATEX change team. This is a model that was developed in order to improve the efficiency of substance abuse treatment programs, and we're going to train Ukrainian experts so that they develop the ability to carry this on when the research is done. We're going to look at what happens to people afterwards to see what is the efficiency of getting into treatment, and we're going to compare what goes on before with what goes on afterwards with regard to entry and retention into methadone programs. So the model that I mentioned that we're going to use is this NIATEX model. It is an evidence-based intervention. It is a model of process improvement. It's perfect for operations research. And it is specifically to look at behavioral health care or substance abuse treatment to improve both access to and retention in treatment. The aims are to reduce the waiting time in order to get people into treatment quicker. If you have all of these registration problems, people will wait forever. So we want to get rid of the registration process. We want to decrease the fact that a person is scheduled to come in, but they don't show up. And we're going to do that through phone reminders. We're going to increase admissions and reduce attrition. The 5 principles of this model are to understand and involve the customer. So that's why we have to speak with the customers. We also have to speak with the clinic itself to figure out what it is that they want to do. How do they want to change? We have to then go in and fix the key problems. So that is if the secretary doesn't schedule patients, or the nurse closes the clinic down at 9 o'clock and doesn't let the last 5 patients who had a flat tire come in, that she has to learn to be flexible. We have to pick a powerful change leader, and I just did that today. We've got actually the guy who is in charge of the National Ukrainian Drug Policy Bureau. He's a general, so he is very invested in this, and so he's going to take this on. So I've got someone at the highest level who is supportive. I want to get ideas from outside of the organization and the field. So we've got people from WHO, from the World Health Organization, from UNODC, but we've also got NGOs and other organizations here within the country to be involved. And then we're going to use a rapid change cycle, which I'll show you on the next slide. So here's the model. It is called, there's a ton of them out there, but it's plan, do, study, act. So we have to plan the process, which you've heard about. We're going to train the trainer and do the work. We're going to study the processes of waiting times and whether people show up for their appointments, and to increase the entry into MAT, and to reduce the sort of discontinuation or attrition so that we can improve the medication-assisted outcomes. And what's important is that we select the health outcome indicators in the research framework. And the framework is exactly what I'm showing here, but the sort of indicators might be housing, getting a job, working. It might be reducing their injection drug use. It might be not getting HIV infected. So we have to select those indicators to make sure we use the right ones. And so what we do is we go to our sort of national partners who say that this is what we want to see if it works. And so we are working with them to do that. Now, the question that we have to ask ourselves is that if the NIATEX model does not increase the number of patients on OST, that is, increase capacity, will it be the fault of the intervention? So once again, here's the operations research issues. Well, one of the things that could happen is that the funding levels could change. For instance, most of the substitution therapy is paid for by the Global Fund, but we know that the Global Fund is going to reduce. And so if there's less money to treat, you can't do more unless, of course, you reduce the dose of methadone, for example. They could, as a result of having less money, change the entry requirements, so only certain kinds of patients could get in. We know that the procurement could be a problem. There's a whole discussion now about moving from pill form to liquid form of methadone. And then, of course, we've learned, and we learned this just last year, that a local event could change the attitudes towards medication-assisted therapy. A physician in Odessa was actually imprisoned in CISO because he was prescribing buprenorphine, but his license went to his house and not to the clinic, and so his license wasn't on site. So all the doctors in Ukraine are now afraid of what would happen if their license wasn't with them to prescribe this. So that has actually reduced the number of narcologists who are willing to prescribe. So we know that these local sorts of things can happen, and so we have to measure them. So the next step is we need to present our findings to individuals who have a stake in the process. So we want to, once again, I've told you, we picked a powerful change leader. We've got him. He's going to hold the meetings. He's going to bring all the important people from government, from NGOs together on a every half-year basis. We're going to present these findings to a diverse audience so that people can reflect upon them and say, oh, what does that mean? We are then going to ask for feedback and advice. And then what we're going to do is we're going to change the implementation to see if we can actually make it better. Or if it's perfect, then we can say this is what it works and this what doesn't. But we always have to reassess the findings because things start to go bad if you keep doing the same thing over and over again. So the sort of challenges that we have, as well as the opportunities, are that there's oftentimes insufficient coordination between the people who give out the money and the people who take the money. And so contracts change, NGOs change, they come and they go, and one may be more committed than the other. So that's one of the things that we have to think about. It requires very interdisciplinary collaboration. In this particular project, for instance, we've got medical anthropologists, we have epidemiologists, we have intervention scientists, we have cost effectiveness scientists, we have mathematical modelers. So all of these are required to do this sort of work. One of the things that's been interesting is that not everybody agrees to the same methods. For instance, some people said, why do the cost effectiveness analysis? Just do it. And I said, well, we probably need to do that. So because I want to make sure that we're doing something that's the most cost effective, especially if we know that the money may disappear. We know that there are different expectations between researchers and implementers about the validity. That is, are we doing the intervention the right way? And if we expand it, can everybody do it? That's one of the reasons why we want to create expertise that's within country, so that the minute that the project is over after 5 years, that there's no infrastructure that's left. And so those are some of the challenges that we think about when we're doing this sort of work. So let me just summarize that HIV and substance abuse are inextricably intertwined, and they negatively impact each other. That effective treatment for opioid dependence can improve HIV treatment outcomes. We've seen that from a number of different studies. But the challenge here is not knowing if MAT works, but how it can be implemented. So we're not really saying if it works, because we know it works, but it's how you implement it that can be the problem. And so we want to learn better about that. And that operations research and implementation science are important ways to test and improve your system and health outcomes so that there are benefits to the individual, to your community, and in general to society. Thank you very much. Spasiba. Are there any questions? So I saw the only thing I can read so far is spasibo, spasibo. There are a couple of other things that are written in Russian that I don't understand, so if we need a translator, maybe they can tell me what it says. Let's see, that looks like Victor says thank you. Are there any questions, or are we have we completed our session? One second. I'm going to have a drink of my favorite beverage. Okay, we have a question. Does someone want to translate the question for me? Okay, great. So the question is that, or the comment first is, antiretroviral therapy is usually lifelong. What are the terms for medication-assisted therapy? And the answer is a little complex, but in general, if a person has been addicted to heroin for a long time, that is over 2 years, they're probably going to need to stay on substitution therapy for many years also. If they've only been using heroin for 6 months, they probably don't need medication assisted therapy. They probably need detox, and then they need lots of intensive counseling. And so I currently have patients who have been on medication assisted therapy like methadone for 40 years. And those are patients who had very, very severe addiction. It all depends on the client, but the answer is that they're going to need to be on medication-assisted therapy for probably many years before they're better, because it's a brain disease, and you have to keep them on the substitution therapy long enough for their brain to heal. And for many people, it takes several years, and for some people, it never heals. Was I supposed to type that or just answer that question? Is there another question?